Dear participants, good morning, good afternoon, depending on the time zone where you are in. So welcome to the PACE webinar. We welcome colleagues from Tajikistan, Kazakhstan, Armenia, Georgia, and other countries. We are very happy you have joined, and we see that more colleagues are still joining. So we are starting our webinar. Just a second, I'll share my screen. So, first, traditionally, I would like to start saying that we have two working languages in PASTE, Russian and English. So you can choose the language that you prefer. You should press the globe button at the bottom of your screen and choose the language that is most convenient for you to listen in. And today we welcome a professional from the Czech Republic as our speaker. And this is Martin Lucka, PhD-R, PhD, founder of the Center for Palliative Care in the Czech Republic, a psychologist and associate professor at the Department of Medical Psychology, third medical faculty in Charles University. Today, we'll overview the experience of the Czech Republic in the field of palliative care over the last 30 years, of course, what has been done and what still has to be done. Just a couple of seconds and I'll give the floor to our speaker, to Martin. So for those who don't know PACE, just a couple of words about us. So PACE is the Foundation for Palliative Care Education. It's a charitable foundation based in the UK, and we support palliative care professionals in Central Asia, Caucasus, Eastern Europe, and the Baltic countries in acquiring knowledge and exchanging experience. So we have a lot of different initiatives, and today I'll also share a couple of initiatives that are open and that you can join. Now, in the chat, you will see the link to our website. We have a publications section there, and you can see all the documents, materials that we've published. We have different digests, etc. And on top of this, also you'll see the link to subscribe to our newsletters. It's a regular thing, so that's how you can be in the loop about what we are offering to you as professionals in PASTE. One of the opportunities that we have open now is the Professional Mobility Grant Program. This is for professionals from the countries where PASTE is present. If it's interesting for you and if you match the criteria, then you can use this QR code to access our website or just use the links on our social media. And you can apply for grants that can support you in participating in different events, such as scientific conference, any webinar, any workshop, depending on the tasks that you have in front of you and depending on your demands. So the deadline is the 7th of April. All the information is available on our website, and you will see the link in our chat. On top of this, PASTE is quite active on social media, and I guess a lot of people now have a Facebook, Instagram, or LinkedIn, so please join us on those social media platforms and follow our news, share them with your colleagues. We always welcome new professionals. We'd really like to keep in touch with you, and social media is a very good instrument nowadays to be in line with all the news. On top of this, I would like to announce a webinar, educational webinar. It'll take place on the 29th of March. So this is the second webinar in the series of webinars on learning tools. Actually, it's also connected to the topic of our webinar and to what Dr. Lucka is doing. So the next webinar will be about understanding whom, what, and how exactly to train in palliative care. And we will have an established expert, Ismina Kabirhanova, as the speaker at this webinar. So please just get registered if you're interested in this. You can see the links in all the places that I mentioned before. On top of this, we have the chat of palliative care professionals. This is a closed Telegram chat, and we are very happy to invite and welcome professionals regardless of their field of expertise. Those could be nurses, doctors, social workers, everybody who is connected to palliative care. We welcome professionals from Caucasus, Central Europe, and Eastern Europe, Central Asia, and the Baltic countries. So you can just follow the link in the chat and fill in the form, and we will add you to our group chat. Once again, our webinar is conducted in 2 languages because we have 2 working languages at PASTE. So it's Russian and English, and you can just press the globe button at the bottom of your screen and choose Russian or English. An important announcement, we have interpreters working for you today. Our names are Anna Akmaeva and Ksenia Ruzova. And during our webinar, we'll have the following agenda. First, our speaker will present his slides, and then we'll have Q&A session. You'll be able to ask your questions with your voice or just text your questions in the chat. It would be very nice if you could also introduce yourselves in our chat, because we don't know all of you, those who've joined, so it would be really nice to know where you come from. You can write both in English and in Russian. So now I'd like to give the floor to Martin. Actually, Martin, very jealous of you because you live in a wonderful city, Prague. I guess some of us have visited, some of us are dreaming about it. I guess that's one of the most beautiful cities on earth. So we are jealous a little bit that you work with such a beautiful background, let's put it like this. And we would like actually also to comment on why we would like to discuss the experience of the Czech Republic and why this experience might be valuable for the representatives of the countries that have joined today and those who will be watching us on YouTube. As in many other countries, actually the Czech Republic has gone quite a long way from some fragmented initiatives to the integration of palliative care in the healthcare system and social care system. This was probably also a bumpy ride, and we'll learn about it more today. But this is just a very good example of the initiatives, public initiatives, and different research and the government support that can get united to lay the foundation for the high quality palliative care. And I'm sure that today, when Dr. Lucka will be speaking, some of you, our participants, will recognize yourselves, right? Because some of you are now working with the mobile teams. Some of you are now working to open a palliative care center. Some of you are drafting the laws, bylaws, and you try to integrate those into the system of medical insurance in your countries. So I'm sure that you will actually find some similarities. And separately, I would like to say a couple of words on the Center of Palliative Care, who was founded by Dr. Lucka and which Dr. Lucka represents. So now this is the major provider of the palliative care services in the Czech Republic. On top of the training, the center offers research, and also it has a lot of other different functions and areas. And I will not take this piece of the cake from Dr. Lucka, because Dr. Lucka will talk about this himself. But as far as I understood, the palliative care center also offers some commercial services like training, etc. It's all all very interesting to us to know about, and that's why we would really like to get to know more about the experience in Czech Republic, and we ask our speaker to talk about it. And we really hope that this will be useful for our participants. So, Dr. Lucka, now over to you. It'll be very interesting for us to listen to you.
Okay. So good morning, everyone. It's really a great pleasure to be here today with you. And thank you very much for this very kind introduction and all the kind words, not only about Prague, but also about our country in general and our work with the Center for Palliative Care. I think this is really amazing what you do with PACET, because I'm a living proof that we can learn so much from each other, thinking about, international experience and sharing our, mistakes and efforts. Maybe that this is not on the slides, but you have just inspired me maybe to say a few words at the beginning about my personal journey as Martin Lucka, because I think that might be perhaps inspirational for some other people if they are actually working on the same agenda as we are. When I started in like being interested in palliative care, I was still at the uni. I was studying psychology, and I really fall in love with palliative care through reading books about existential psychotherapy and how death is really one of the key topics for our lives, basically. And then I discovered palliative care, but back then there was nothing much really going on in the Czech Republic. So I had to look to other countries to learn from their experiences. And I had a chance to do my PhD in the UK and to spend some time in other countries as well, in the Netherlands, in the United States. And I really appreciate how different the healthcare systems can be, but still we can learn a ton, really, really. And if we are open enough, I believe that this is, the way how to accelerate all the system changes that we want to see in our healthcare systems across the world, by actually using the examples and the role models from other countries and the lessons learned. This can help so much, at least in our country. It really helped a lot. It doesn't solve all the problems. And of course, we had to kind of localize all those great ideas from colleagues from abroad. But it definitely helped our cause when we were able to say, hey, look, in so many other countries, they do this, it really works. And let's think about how we can adapt all those models in our country. But I think palliative care has one great advantage compared to other fields of people's endeavors, that needs of people approaching the end of life are very much the same all around the world. So if you look at the data and some research and some service models from other countries, you can more or less say that they are trying to solve the same problem as we are facing in the Czech Republic or in Kazakhstan or in Japan or in China or in South America, everywhere, because the needs and the values are very much shared. That's my experience, and I really believe in that. That people feel the same pain, they feel the same anxiety, and we are really trying to figure out how to help them. So I'm really, big fan of PACET now, and I'm really happy to be here today and share our experience. And if I could help in the future to anyone, please, just reach out, and we'll be happy to follow up later. Okay, so let's start with the slides. I hope that I will find them. Yes, here. I'm just wondering if I'm on the right channel, but hopefully I am.
Yes, it's okay.
Okay, perfect. Thank you. So my presentation today will be divided into 4 sections. In the first, I would like to speak very briefly about our center. Then I would like to describe how our healthcare system works. I think that's important to kind of base all the slides and all the information in the realities of our system. And then I would like to share with you 5 crucial points in the development of palliative care in our country, at least as I see them. Of course, there would be many other important moments and many more important initiatives, but these would be just 5 that I would like to highlight, and we can definitely discuss, the other things later. And at the end of the presentation, I would also like to show you 3 examples of projects focusing on system change that we have done with my organization, as probably, hopefully, again, some inspiration for you guys who are working on improving palliative care in your countries. So this would be just like some of the lessons that we learned and the way how we actually approach this challenge or this problem. So my organization, as Roman already kindly said, is called Center for Palliative Care. It's an NGO that I established in 2014. We are main provider of palliative care education. We have around 3,000 people actually every year attending our seminars, webinars, all different courses that we run. We do a lot of trainings for nurses, for physicians on communication skills. We also run a lot of LNEC courses. If you are familiar with the LNEC course, which is the end-of-life nursing curriculum for nurses, basically, originally founded in the US, but they have spread across the world. And I think this is also a good example of the program that I would highly recommend to anyone to adapt in your particular countries, because the program really has some respect and value across the countries, and they provide a lot of support and kind of like mentoring for those who want to adapt this program nationally. So that's one of the things that we started with many years ago. We also do a lot of research because, as you will see throughout my presentation, I really believe that research is the key how to move on palliative care. For many years, at least in our country, and I believe you might have the same experience, palliative care is really very emotional area, and many people are, really emotional when we speak about palliative care. But you know, that's working only until some moment. And if you think about system development and really improving palliative care and access to palliative care at national level, you will definitely encounter people who will not get emotional by, touching stories of patients, and they will want to see some data, some, models to implement in the system. And I believe that the data is really the key how to convince all the policymakers and the stakeholders that must be involved if you really think about this, seriously. So we do education, we do research, and we also do something that we call service development projects or system improvement projects, when we target different aspects of health and social care system in our country, trying to improve and help to solve some problems that we see as barriers for further development. And as I promised already, I will speak about some examples later. So we are NGO, but we are also trying to be independent, at least partially. So we actually sell our services, which was, something that I had to learn how to do it. And, again, it's kind of like, can you actually make profit and can you make business? I believe, yes, you have to get some kind of financial independence. My experience in our country, and I will speak about it again later a little bit more, was that many funders and donors are really interested to see that the NGOs are trying to be independent and that they are not only relying on somebody else financing all their work. So this is something that really helped us a lot to see that we to show that we are actually working on our financial independence as well, and by providing the services that are needed by the system, such as education and expert consultation services for, again, policymakers, various councils, Ministry of Health, even like local governments in regions. It also helped us a lot to kind of build the reputation for the organization and to further support the networks and the relationship with service providers. Okay, just for those of you who have never been to Prague, actually, please come. Actually, I'm actually moving out of Prague this summer, so there are many other beautiful parts of the country. But if you are visiting the Czech Republic, probably you will show up in Prague. So we are just in the middle. We sometimes call that the Czech Republic is the heart of Europe. Of course, I'm not sure whether people are okay with that, but we call Czech Republic like the heart of Europe. We have a population about 10 million inhabitants. We have been part of the EU since 2004, which is, I think, important again because it helped us to use some of the European legislation and regulations also to base our efforts in palliative care. There was a beautiful declaration of all the ministries of health of the European countries published by EU, which was supporting the idea of wide implementation of palliative care 20 years ago, and we have been using that, since then as a example of something that we have to really catch up with if we want to be, still up to date with the other European healthcare systems. We have around 200 hospitals, which is quite a lot. The Czech Republic is around 79,000 square kilometers. So 200 hospitals on such a small area is actually quite a lot. Some people are, really criticizing this nowadays, saying that this is a very medieval model of healthcare when you have a hospital around every corner and people are kind of thinking that they will get all the medical services just like that in the nearest small town. So this is actually undergoing right now some kind of reform in our healthcare system. And we have also around 1,000 long-term care facilities, which you can imagine first as a nursing homes, which I believe would be available in many other countries as well. But then also we have something called long-term care hospitals, which would be not social care, but medical care facilities with physicians and nurses, but they would be also providing long-term care. So patients would be there for months usually, and many of them would actually be patients at the end of life as well. I'm saying this because at the beginning of my work, I realized that if we really want to see a difference at national level, it's not about developing just one kind of services. So it's not about the home hospice, it's not about hospital palliative care team, but it's really about thinking about the bigger picture. And it's like a puzzle that you have to put all these things together. Of course, you have to have specialized palliative care, you have to have home hospice, you have to have hospital palliative care teams, but it would disbalance the system if there were, amazing hospices and nothing in hospitals, which was actually one of the lessons that we took in our country. So for those of you who are thinking about your country, I would highly recommend and really recommend to think about, the bigger picture, thinking what's working and what's not working. And if we want to support the system, we have to do it in balanced way, supporting all those aspects. So you have to support all the general palliative care providers as well as the specialized palliative care providers. In our country, we are also lucky to have very good access to opioids, but I'm aware that it's not like that in many other Eastern countries. So, we are just lucky. In the Czech Republic, opioids are very well available, almost like any physicians. This is generalization, but most clinicians who take care of patients at the end of life would have access to opioids. If they want, they can prescribe it. If you are a GP, if you are internal medicine specialist, if you are a pediatrician, if you are a geriatrician, oncologist, almost all of these disciplines that are relevant to palliative care can prescribe opioids, and you can pick them up in your local pharmacy, basically in your town, so you don't have to travel to the capital or anything like that. So I think this is also very important. And again, there actually have been a number of European initiatives supporting access to opioids. And I know that this is one of the crucial issues, so we can speak about it later if you want, but this is something that we are lucky to have now in the Czech Republic. And we have about 5,000 GPs, which is, I think also very important topic to consider, because they should be, in ideal world, one of the main coordinators for patients approaching the end of life. So again, for everyone, I would recommend to think about what are we providing to support GPs in their role in providing palliative care. And I will speak about it later. In the Czech Republic, we have, public healthcare system covered by universal mandatory public health insurance. So people are giving a small portion of their salary. Sometimes it looks like quite a big portion, depends on your political standpoint, but then you get access to healthcare for free, from the GP visit to neurosurgery, you would get actually be covered, and this all would be reimbursed by the public health insurance. So it's the similar system like in the UK or in some other countries, is so-called free healthcare. We also have the social care system that I've mentioned already briefly, and they are important regarding palliative care. because this would cover the whole area of nursing homes and many community services that would be labeled as social care. And this is actually helping a lot. And we have been working with nursing homes for 5 years now, and I will speak about it later again as well. And this was such an important lesson for us that many problems can be actually solved, or at least supported by uh, building bridges between these two worlds, healthcare and social care. Our experience with our policymakers was that sometimes they are happy to blame the other side. So the Ministry of Health be saying, "Oh, you have to take this to Ministry of Social Affairs," and the other way around. But palliative care is a beautiful example of really multidisciplinary topic. And in those countries that have separated government institutions to deal with healthcare and social care, again, I highly recommend to get them both on board as soon as possible. And I think it also can work for you that palliative care is one of the topic that they, at the end of the day, will be willing and able to recognize as something important that they should work. That was our experience in the Czech Republic, that both these ministries said, okay, so let's find a way how to make it work for all of us. And then if you have one of the ministries on board, the other is kind of like saying, okay, we should do something as well. So this is just important. And right now, again, in the Czech Republic, we are undergoing a huge reform in how we think about this integration, because it's not only about palliative care, but many other aspects of healthcare also have, this kind of intersectionality issues. So I think this is also important. Okay, so let's start with the crucial moments and dig into the palliative care more specifically. So I would like to start with start of hospice movement. In the Czech Republic, in the modern history of the Czech Republic, palliative care really started with hospices in 1990s. So we had this amazing lady, Dr. Marie Svatošová, who is the founder and the mother of the hospice movement in our country. What she did was actually that she kind of emulated the model of St. Christopher's Hospice in London that I believe you are familiar with, the first modern hospice in the UK. And she visited England, she visited St. Christopher's, and then she was able to raise money and build the first inpatient hospice unit in the Czech Republic. It was, and it still kind of is, an NGO outside the mainstream healthcare system. This is important, and I think this is also one of the important lessons that we actually experienced, that since this first hospice in 1995, in all other regions of the Czech Republic, services like this actually started showing up, but they were really standalone outside of mainstream healthcare system, very much funded by donations and by fundraising and philanthropical activities, which is completely okay. And I think for hospice care in most countries in the world, this makes sense until some point. And I dare to say that our hospices in the Czech Republic are really, really good, and that they are comparable with inpatient hospices in other Western countries. Our problem was that they kind of ended up in their own world, and that the link between this hospice movement and the mainstream healthcare was basically non-existent for almost 20 years. So we ended up in a very strange situation when we had really excellent facilities providing very good palliative care, but only less than 3% of people actually died in hospice facilities, because they were so outside of the mainstream healthcare system that most physicians in hospitals have never been there. They wouldn't know anyone who worked there, and it was very difficult actually to get referral to hospices. So the usual way how you would get to a hospice would be just hearsay, and that you have a friend who has a friend who has a friend who had someone in hospice, and that would be the recommendation and the way how you would actually get the information. So when we established our organization, this was one of the mission that I said, okay, we have to work on this. We really have to open the door and open the windows and everything, and really to build the bridges with the mainstream healthcare, because it doesn't make any sense to have excellent services who are basically not used, and people don't really know much about them, and there were many stereotypes. And if people heard about hospices, they would very often thought that it would be only like for Christians, because the first hospice was linked to Catholic charity. So many people would feel that, their goal is to baptize everyone before they die, and that's it, which was, of course, not the case at all. But people were really kind of trapped in those stereotypes. And because there was very limited communication and experience in the mainstream healthcare system, it really stayed like that for many, many, many years. But still, they made a really great first steps. And I think everyone in the Czech Republic is really grateful to Dr. Svatoshova, because she was also able to negotiate the first reimbursement model for hospice care, which was actually established in 1998. And since then, hospices are partly funded from the national insurance, which was a great achievement for her. And I think it was really amazing that she managed to negotiate the financial reimbursement scheme only in 3 years after the first hospice was established. So this was really great achievement. Nowadays, as I said, we have around 17 inpatient hospices across the country, which is more or less what we need. There is at least one inpatient facility in each region. We have 14 regions in the Czech Republic, and they altogether provide around 500 beds. So if you think about the WHO or the EAPC recommendation of around 100 hospice beds for 100,000 population, we are almost there basically for the number of inpatient hospice beds that we would like to see in the system. Okay, so that was the inpatient hospice movement, and it really all started with this. The second important milestone, at least as I see, was the establishment of a home or community hospice care, because that's, in many countries around the world, including the Czech Republic, if you ask people where would you like to die, most people will say at home. So we really had to start thinking about how to bring all that expert hospice palliative care to people who actually can and want to stay at home until the very end. And all this started with an organization called Cesta Domů, which Cesta is way and Domů is home. So you can say it's like a way home or homecoming. And this was the first home hospice organization established in Prague in 2001. And I want to highlight their example because it's a really very special organization until nowadays, basically. And why? She was actually started with an artist, Martina Špinková, who is this elegant lady on the picture on this slide. She's not a physician, she's not a nurse, she's a painter. But she was really passionate about, helping people facing, the final phase of their lives and supporting them to stay at home. So she was really enthusiastic, and she was able to uh, kind of gather enough people, including nurses and physicians, who felt the same passion, and they really started working together on this organization. And I think this was really important because as she was not a physician, she was not a medical person, she was really close to uh, lay people way of how to phrase all those things around palliative care. So Cesta Domů was very successful in communicating and doing like PR for their work, and they are still one of the best organizations in our country to do this. And from the very beginning, they also started doing other things than just providing care. And I think this is also something that I would like to recommend to those of you this might be relevant, that if you really want to make a change at national level or like system-wide level, it's not only about providing care, but it's also about public awareness. It's about supporting, sharing the role model and the good practice across the other services in the healthcare system. And Cesta Domů was a really nice example of that. So when they started, they also opened a specialized library. They were actually, buying books from abroad, and they really built a very small but very good library for palliative care. So even me, I was studying in another city in the Czech Republic, and as a young student, I would be actually coming to Prague to borrow books for my bachelor studies and for my master thesis. And it really helped to build people who were thinking about palliative care, and having access to all those resources from like their university degree, basically. I think this was a super important resource for our palliative care community in the Czech Republic. And they are also, the Cesta domů was also supporting public campaigns and lobbying activities. And they also even started their own publishing house. So nowadays, they are basically the biggest publisher of palliative care related books in the Czech Republic, when they would be translating books from abroad, but they would be also supporting local authors to really wrap up their experience and write a book about it. So, because if you think about development of palliative care, you will need textbooks and you will need resources that could be used in nursing schools, medical faculties, and all the other educational institutions. Okay. The third important step was the establishment of Czech Society of Palliative Medicine. In the Czech Republic, we have like an overarching body which is called Czech Medical Society, and all the medical disciplines would have their own medical subspecialty organization, which is usually responsible for specialization training for physicians, but it's also the place where Ministry of Health would go to consult new legislation relevant to cardiology or to GP or to palliative care. So this was very important that in 2009, Czech Society for Palliative Medicine was established, and it immediately became a very important partner for Ministry of Health and for other policymakers. So I think this is also one of the things that you can't miss. I think you have to do it, and it can really accelerate all the further activities very well. So I think to establish a really good professional society as a platform where people can meet and speak together and like think together about what's necessary to do, you can create some like strategic plan for organization such as Palliative Medicine Society, and it get recognized because there are other similar organizations for other similar disciplines within the medical field. So I think this is a step that really can't be missed or skipped. And I've already mentioned the medical specialization. Czech Society for Palliative Medicine actually helped to make this as independent subspecialization for physicians. In the Czech Republic, the original specialization was established even before we had our own organization in 2005, but it was a combined specialization in palliative and pain medicine. And many physicians undertaking this specialization would actually be focusing on pain medicine, treating chronic pain patients, but very few of them would be actually interested to do palliative care as their full-time job. So in 2011, Czech Society for Palliative Medicine managed to kind of rip it off and make palliative medicine as standalone medical specialization or subspecialization for physicians. And we have around 15 to 20 physicians every year actually completing this specialty, which is quite a lot. I'm not sure about the situation in your countries, but for the Czech Republic, this is more than clinical oncology, for example. So palliative medicine is really becoming more and more popular, and having the subspecialty is another really important thing to recognition of palliative medicine as important field. I had a meeting yesterday with colleagues from the UK, and they shared their situation that palliative medicine in the UK is now the 11th largest specialty in the system, which is actually really, really great achievement. And especially at the level of specialty, when you would have oncologists or internal medicine physicians or GPs who can do palliative medicine as a subspecialty, I think this model really works pretty well. Okay, now the fifth and the final critical moment was, of course, money and finances, because, all these beautiful things, cost some money. So, where we can find them, how this works in the Czech Republic. I must admit that when I finished my PhD in the UK and I was thinking about coming back to the Czech Republic, I was a little bit nervous and, really a little, I can say pessimistic about, how we will manage to find money for that, especially after being a few years in the UK, with their long tradition of philanthropy and charity work, and everyone is happy to volunteer for charities, and this is such amazing thing in the UK. We didn't have this at all in the Czech Republic, due to our history, and while we were, as we said, under the communist era, people were not really willing or even able, even if they wanted to do anything like that. So we didn't really have much tradition of giving out to charities or offering your own time or resources or finances to other organizations. So I was kind of like skeptical whether this could be done, but I want to, share our experience that, after a few years, it really changed. And even when I came back in 2014, I learned that there are people and, successful entrepreneurs and companies that are interested in supporting good things. And even if was not really highlighted in news, and and I had to kind of like really learn about this system. Nowadays, I'm very grateful and really excited to say that we have actually many really big foundations and companies, and even like personal philanthropists, people who are really willing to support good things. And after 30 years of Velvet Revolution, I think it's too late for us, or like really to blame the previous regime 40 years ago that we can't do things. We can, and it's about finding the way how to build relationships. I think fundraising is not about getting money from someone. It's really about building relationships with people who share your passion and share your vision. And my experience was that we were able to find really clever people and really successful entrepreneurs who were actually interested to support systematic change. So, some people are always willing to give you money if you show them sick old lady dying in the bed and their granddaughters and dogs and cats around. They will send you some money to do something good for that particular lady, and that's great. But if you think about, change at national level, my experience was that we had to find different kind of donors who don't get that much emotional, and who really want to see some projects that aim to make systematic impact. And they were actually willing to give us quite a lot of resources, not only financial, but also other kind of support to really make our projects being successful. So one of the examples was the Abacus or the Avast Foundation, who actually invested already more than 6 million euros since 2014 to many projects around the country. And it was really started by a private company doing antiviruses for computers. And they were actually so much important. They still are one of the biggest moving forces behind palliative care development in our country. But we actually were lucky to find more and more donors every year, kind of like joining these efforts and being willing to discuss what other can they do to support palliative care development in our country. Some of them from big banks, some of them from a personal, like a really private philanthropical areas. But you will have to find money. And I think one of the lessons that I want to share with you is also about how to use this money in countries where we have public health care, because this is important. In the United States, every single hospital would have a plaque with the name of the person who built that building or who is supporting the department. This wouldn't really work in our country. When we have free healthcare, people don't feel that they should pay those service providers to do their job if this is covered by the national insurance. So my experience was that these donors are actually willing to support pilot projects to really see, okay, let us work together on something new, on something important that will really help our system to work better. And we don't want you to pay for it forever. No, this should be the responsibility of the government if we have, free healthcare in our country. But the government is usually very slow in implementing and in piloting and in doing new stuff. So my experience was that we were really successful in building collaborations with donors who were willing to give us quite a lot of money to do good pilot projects and to show the data and the impact that the pilot projects can do, and then to use it in advocacy and a support for policymakers. And this is the model that we actually replicated already several times. One of the most recent examples of amazing philanthropical support is the Vlček Family Foundation, which is again private family foundation, which was established a few years ago in our country to support pediatric palliative care. They are actually specifically looking at pediatric palliative care, but they are amazing and they put such a huge amount of money and resources into this issue that one of their ambitions is actually to put us really on the map of the world pediatric palliative care as one of the leaders in next 10 years, and they are really making a great work. So they would be definitely willing to discuss any kind of international experiences or international collaborations, as well. If you are working in pediatric palliative care, let me know and I'm happy to put you in touch with them. So the final, did I have already the fifth? Okay, so this is the sixth maybe lesson. Sorry, this is my mistake, but this is not a specific topic, but it's more like an underlying principle that you really have to work on collaboration. One of the great thing that I heard from one of my mentors was that you can never achieve big things alone. So if you really want to make the change big, you have to do it together with other people. Sometimes if you are the change maker, you will also make other people mad about you and they will be angry. And especially in the new field, such as palliative care, we had to deal with the issue of having many pioneers, at once here. So, people from the inpatient hospice movement thought that they really are the pioneers who started it all. Then people who started with palliative care in hospitals thought, no, we are really making the change here because we are bringing the big palliative care to the mainstream, really taking care of most people who are dying in hospitals. And sometimes you can see that even in this beautiful topic of palliative care, we had to solve the problems with, how can we work together and we have the same goal. So let's try to find a way how to support each other rather than compete with each other. And I think this is, again, very important as a starting principle if you really want to have an impact, that you have to learn how to work with other people and how to collaborate. And then, as I already said, I believe that only data-driven system change will last. So my recommendation would be, even if you start with small local hospice organization, or if you start with big Ministry of Health kind of project nationwide, always think about the data, because eventually your project will finish, or you will find yourself in a difficult situation when you will have to advocate for more resources, and that's usually the moment when the stories of your patients will not be enough and you will need some data. So my recommendations from the very beginning would be, what kind of data do we have? What kind of data do we have to compare with other countries and use it as a leverage in negotiation with policymakers, national insurance companies and other, and what kind of data we don't have, and we have to really gather them. And then think about how we can make it, and how we can actually get this data available. Our organization, my Center for Palliative Care, was established, specifically with this goal to provide the evidence base. So we don't actually take care of patients in our NGO, although we have many people working with us who also work in hospitals and in hospices. But our goal was to be like objective evidence-based provider for policymakers and for the system change. But you don't have to have a specific standalone NGO for that. You can ask your local universities, and I'm sure there will be people working at your medical schools or public health institutions in your universities who actually should be able to do the research and the academic part of that work. And my experience was that academics are really striving for someone from clinical world to be willing to collaborate with them. So if you are medical care provider, if you are a nurse or physician or social worker, and you are thinking about making the next step, you can also do it by linking with your local university and ask them, hey, we need some data to support our advocacy or some other projects. Could you help us to think about this, how we can make this really, really work? So that would be also my recommendation for that. I'm aware of time, but briefly, just the 3 examples of projects that I promised to tell you about. The first of them was looking at hospitals. When we started in 2014, there was basically non-existent palliative care in our hospitals. although, as in many other countries, most patients die in hospitals. So one of the missions that we undertook was to bring palliative care into hospitals. And this was a great example of one of those pilot projects financed by private philanthropical foundation. We collaborated, my organization, we collaborated with the Czech Society for Palliative Medicine, which was important because they put a stamp on that project saying, okay, this makes sense. This is not some kind of, guerrilla suspicious activity, but this is, really well-based, well thought through activity. And we work with 26 hospitals for almost 5 years, helping them to set up palliative care services. One of the great things that we did, I'm really proud of that, but I want to share with you, was that we didn't tell them what to do at the beginning. We convinced the Avast Foundation, and they were actually really willing to do that because they really like this principle in their other programs as well, to provide the money to hospitals, asking them, what do you need? Where do you see yourself? And what would be the next good, impactful step for your organization to make progress in providing palliative care? So we were not looking at, all hospitals must have established palliative care teams with that number of nurses and the numbers of physicians and serving that many patients. We were asking them, okay, let us, help us understand where the needs really are and what you would need to make a progress. So in that group of 26 hospitals, we had large university hospitals that really used the money to establish new palliative care service. But we also had much smaller hospitals who used that funding to educate personnel and to really increase the general palliative care skill level in their hospitals without establishing new programs or new departments or new services. And it was also very important because, as we discussed at the beginning, not every hospital will need their palliative care specialized team. Many hospitals would be just fine with general palliative care, but it was also important for us how to help them with that because it can be even more difficult sometimes to convince the other departments to educate their personnel in palliative care. So this was really good, I think, step that we took that we really help them to do whatever worked for them at their particular moments. And then after 2 and after 4 years of the program, we gathered the evidence about all the different trajectories that the hospital took. And we were also able to see what kind of impact this can have, at different level of institution, also in different regions with different, populations and different needs. Because if you are in a capital with 20 or 10 university hospitals, this would be different to some, other regions where they would have only one central hospital able to provide specialized care, and you would have to think much more about, the distribution of the workload. And as in all of our programs, we also published at the end of the project, we also published guidelines, really gathering all the evidence and the experience and making this widely available for anyone who is interested, and also to, again, policymakers and stakeholders at all the levels, from the government to the local council towns and hospitals. And I think this is also very important if you are starting initiatives like this. From the very beginning, think about the end. Think about what we will need to have in our hands when the project is finished to be able to build upon that. Again, it would be great if you provide care for 200 patients, amazing, but what next? And how will you be able to negotiate with the stakeholders after the project ends? So my experience was, it's really important to think about what kind of resources and outputs you need to take out of the project. And you have to think about this from the very beginning. Otherwise, it's really difficult to, do it backwards. It doesn't really work. It would be very difficult to do it. We have a similar program for nursing homes. As I said already, nursing homes in our country are a very important provider of end-of-life care. 5 times more people die in nursing homes than they die in hospices in our country. So it was very important to figure out how to support them in providing end-of-life care, because in many nursing homes, people would be transported to the hospital to die in hospital for the last few days or last week of their lives, because nursing homes would be not confident in providing palliative care. So again, we had a group of organizations. We had 2 rounds of this program, 15 and 50 nursing homes. And what I want to highlight from this program was that we had to educate them. We provide, again, mentoring for systematic change, because especially in nursing homes, it was really about changing the culture in the whole organization. This was very important, that from the director of the organization to the maybe the person in the reception, all of them would have to know about, okay, palliative care is part of what we do, and we are here to really support people to die with dignity and, to live as well as long as possible. And what we did in this program was that we actually developed a brand new role for nursing homes, which is called Coordinator of Palliative Care, which has not been existed until we started the program. So we actually taught the nursing homes that they will really need to have this role very specifically described, and there must be a coordinator role in the organization. The success was that after the program ended, 28 out of those 30 nursing homes were able to convince their, funders to finance this position, because it made such a great impact. We reduced terminal hospitalizations in those 30 nursing homes by 30% over those, 2 years and 2 years program. So this was really a huge impact that they saw. And we also made a really great achievement in terms of developing advanced care planning tools for them. Because, as you might know, palliative care is not about morphine, but it's about planning the care, right? It's about ACP, it's about advanced care planning. So we also developed a lot of tools that they can use to make a good goals of care conversation with the residents and with their families, and really to develop good plans that can be used to provide end-of-life care and palliative care in general. And one of the lessons that I want also to share with you is that in all our programs, we would be using very extended advisory boards. So we would usually invite people from all those important institutions and stakeholder groups to come over as observers. And this was very crucial in the program for hospitals, as well in this program for nursing homes, as well in the last program about emergency medical services that I will speak briefly about in a minute, that we always ask people from the Ministry of Health, from the Ministry of Social Affairs, from insurance companies, from other important medical subspecialties, could you please nominate someone from your institution to become a member of our extended advisory board? We don't need anything from you, don't be afraid, because sometimes people, especially from ministries, they are kind of like, oh, there is something, going on. We don't want to get, in a position that we would have to promise something, because this is very difficult for them. But we always ask them, please come. We just want to know your opinion, and there is nothing, mandatory coming out of that for you. So we have been very successful actually in this, and these extended advisory boards were very important in scaling up and scaling out the results of the programs. So again, I would highly recommend you to do this if you want to do some kind of like nationwide project. The second lesson that I want to share with you was to building community of practice. As you might have noticed, we would usually have a group of 15, 20 pilot organizations, and we would actually spend quite a good amount of resources on really developing a community of practice among those organizations, helping them, building trust among each other, sharing, practice together. And this is very important, because this will build a platform that will outlive the program. So even after the program ends, these networks will still be there, and they will be able to, again, sharing their good practices and also building the capacity for training further, generations of people or organizations who are keen to learn from their experience. So I think supporting the community of practice is very important, because in this field, many organizations and many people would feel that they are alone, that this is just us fighting against the system. And when you put them all together in one room, and they will hear from each other that they are all facing the same challenges, and they are all trying to find, some new innovative solutions, it again will accelerate the development very much. So letting them know that they are not alone and building the community of practice is important. And the last example is a program that we did with emergency medical services. Because, in our country, and it might be the same in yours, EMS, emergency medical services, is a very special thing. They are like a glue of the system, and they will be transporting the patients everywhere, from home to hospitals, from nursing homes to hospitals, from hospitals to home, and the other way around. And we did some research, and we found that every paramedic every day would transport at least one patient to the hospital, knowing that it's actually not the right solution for that particular person. So we thought, okay, this is again very important provider of general palliative care, and we have to actually work on that if we want to increase again the effectiveness of the system as a whole. We use very much the same strategy as we used in the previous programs. We have 14 different emergency medical services providers in our country. So we ask them to nominate ambassador. So we ask the CEO of each local EMS to nominate one colleague from their organization to become an ambassador, which was a very important step because the directors, they would not be really interested in palliative care. They would be interested in getting more helicopters and, other things for their EMS, but not palliative care. But because they officially nominated an ambassador, that person suddenly got very good recognition within the organization. Okay, so now they can actually say, say to everyone, they can email everyone, hey, I'm the officially nominated palliative care ambassador here, so let us do some work together. I'm providing some education here. I'm bringing some research initiatives and other things, and it's officially recognized. I think this is the thing that I want to highlight from this particular project, that was super important for us to really get this recognition and to help those people in local organizations to become like official member of this initiative. And I'm happy to admit that many of them really exceeded our expectation, that they really were so active, that they developed so many great ideas that we haven't been really thinking about. But by providing them this official position, it really again helped to move all the things forward much quickly than that we would be able to do it on our own. Okay, so the final slide, to just sum it up, what do you need to walk the journey from local initiatives to everyday practice at national level? I think you need passionate pioneers and advocates. Of course, it starts with people. So you have to look around and find people who would be really enthusiastic about doing this work. It will cost them a lot, but I'm sure that in every single country you can find people who would be willing to join you. Don't start alone. Find one or two people who will be doing this with you. Then you have to build some beacon organizations. I think you really have to have some examples that this can work. I was kind of, saying that data is more important than clinical practice. Hopefully you didn't get that message. It's, of course, you need to have good service care providers that can show how palliative care really works and that it really fulfills the expectations. And with these beacon organizations, I think it's really important to think about their educational capacities, because nowadays one of the challenges that we face in our country is that we have extended the network of service providers. And as palliative care is getting more and more popular, we are actually struggling to meet the demand on the educational side of the thing. So many people would like to come over to learn, and we are very busy to actually kind of find spaces for them within the organization. So again, from the very beginning, following the example of Cesta Domů, for example, I was thinking about, okay, we are building the best hospice here in our country. So it doesn't mean only the clinical work, but we also have to build the capacities to be able to share our experiences with the further system. I would try to find donors or money to finance pilot project, and I would phrase it like pilot projects, promising the donors that they will see the results and that we would use the results to negotiate it with the ministries and with the stakeholders. And as I said many times, data, data, data. I really believe that you need a beacon organization, but if you have one, I would rather establish a network with the university than to set up another clinical organization if your goal is really to support the systematic change. because I think that the data is really so much important. Okay, that's it from me, from the slides. I hope that there were at least few things kind of making sense to you. There is my email, so I'll be very happy to stay in touch with all of you if there are any questions later. But I believe that we still have some time for discussion now as well. So thank you very much for your attention.
Мартин, спасибо большое вам за этот невероятно
интересный, Martin, for this very interesting, excellent review of developing the palliative care in the Czech Republic. For me, it looks like an excerpt from a textbook regarding setting the palliative care in a country. Of course, there is not a one single excellent recipe, and of course, I understand that a great deal of work has been done by you and your colleagues and your predecessors to make sure that all this will be done. And thank you very much for looking at this whole system from various aspects, and it's very important that you also focus on people, enthusiasts, passionate people, professionals, initiators, because of course, after all, it all relies on people, and the system can emerge only after someone decides to develop it or to set it up. And it's very heartening because this is exactly what PACED is doing. And now I know where I would like to die. I would like to die in the Czech Republic, if you allow me to do so.
Итак, значит, у нас есть, во-первых, благодарности.
We have see here a lot of words of thanks that we have received in our chat. Thank you for this very productive talk. And Irene Velasquez says that you have inspired here. Well, if you allow, we have a few questions. Do you have 10 or 15 minutes to answer the questions that we currently have?
Да,
absolutely.
Спасибо огромное. Спасибо.
Thank you very much.
Мне бы хотелось
First of all,
озвучить вопрос, который мы получили от
I would like to voice a question that we received from Gulnara from Kyrgyzstan, and she is asking which organization regulates the hospices. Do they work under the Ministry of Health, or is there another body that regulates and governs their activities?
Okay, so the hospices are still mainly funded as NGOs. Most of the hospices are basically NGOs, so they would get at least 50% of their budget from the national insurance because they registered as provider of healthcare, which is recognized by the Ministry of Health as one of the specialties now, so they can get some money and reimbursed for the medical part of their work. But of course, the health insurance would not cover, for example, the work of social workers or the work of chaplain or the work of volunteers or the CEO or like the other things. So they have to actually get some other funding as well. And most of the organization would actually find the other half of their budgets covered by donations or some grants that they can apply for different things. So a friend of mine, really experienced hospice director, told me once that if you want to set up a new hospice care service, you need a nurse and then you need a fundraiser to be able to kind of help you to gather all the fundings. But the regulations are basically the same as for any other healthcare provider in the country. So that would be mainly Ministry of Health, and the standards would be, as the same as for normal hospitals or for other medical fields.
Понятно, спасибо большое.
Thank you very much. The next question that we have: how have you been able to provide such a good access to opioids, and the fact that they can be prescribed by doctors of various specialties, oncologists, GPs, and so on?
Yeah. This is definitely not my work. So, this has been there already. My question would be, how is it possible that opioids are not that available in other countries? Because this is, really not making much sense. If you look at the WHO letter for pain management, opioids are the way to treat even the medium strength of the pain as the medicines for the first choice. So I think it's really normal thing, and I'm not surprised that they're available in our country that well, but I'm very surprised and very sad about the situation in other countries where the access is very limited. So my question would be, okay, what can we do to increase the access in other countries? Because this is not an exemption. I think it should be like that in every country. The other problem that we have in our country is the reluctance to prescribe opioids. This is another story, that opioids are widely available in our country, but many physicians actually don't use them because they are afraid of using morphine, or they think that this is only for very end-of-life care patients. They are afraid of the addiction issues and many other things. So this is really strange that we have very good access to opioids, and many patients would not get them because there are some stereotypes and prejudices about using opioids in a clinical practice. So we actually work with hospitals and GP practices and trying to helping them overcome these barriers. Because of course there are some administrative burdens as well related to having opioids available in your GP office, for example. It must be very well documented how you use it, but it can be done. But it's strange that we have access, but we still don't use it as well as we could.
Спасибо большое. И особенно спасибо за такую переформулировку вопроса.
Thank you very much, and thank you for rephrasing the question. It's again not a matter of their accessibility in the Czech Republic, but their inaccessibility in other countries. And I can say that this is a very big issue for many countries that we work with. And yes, there is a wide interest for using opioids. And if you allow me, I have a question with GR, government relations, and I can see that a lot is done when it comes to working with the government, with various agencies, with the ministries, and you said that the entry to the European Union has been very helpful, and the European legislative framework has been helpful in terms of developing palliative care. But when it comes to political will, it's a very sensitive subject. And do I get it right that when it comes to the Czech Center of Palliative Medicine, it is a very important player in terms of providing connection with the ministry, with the government?
Yeah, you're absolutely right. No, and I think that's because of how our system works. If we work in the system that provides public health care, it's impossible to really make impact without having good relationship with those important stakeholders. So I think this is very important. My experience was that it's not about, making the Ministry of Health your friend. It's about finding the right people inside the institutions, because there will be usually 3 people very, like 3 levels down in the organizational scheme, who would be somewhere in the office at the Ministry of Health doing all the hard work and really preparing all the drafts for the new legislation. And these people would usually stay there even after next election and the next election and the next election. So the collaboration is not about, going on a party and taking picture with the ministry, with the minister himself. It's really about finding the people who will work there with you, who will have the, again, bigger picture available, and who will be able to work with you for a longer time than just, 4 years of this particular political party who is, kind of governing right now.
Спасибо большое. И если позволите, еще
Thank you very much. 2 more questions, and we will wrap up. There is a question from our attendee. Have you been under the situations when your center of palliative care could not come to terms or find a common language with other institutions or the ministry, and what were the situations, and if you have come across with any conflicts, how would you solve them? So it's about collaboration, and it's about being able to find a common solution.
Amazing question. Thank you very much. This is super important question. You know, I consider myself to be pretty nice guy, and I'm happy to like work with anyone who is willing to work with me. But still, I was not successful every single time, you know, and I also had, you know, these very tough lessons of meeting people who were just not willing to work with me, or we just didn't, you know, meet each other in the best way. So absolutely, yes. One of my mentors from the US told me once, start working with those people who like you, and the other will join later. So if you feel that it's not really working, you know, with this surgery department in your hospital, no, don't waste your time too much and just find someone else. And maybe, you know, the other department next door will be willing to work with you on that. So let's start working with them. And maybe that surgery guy will come, you know, next year to your presentation in your like seminar and asking, oh, could we probably implement this in our department as well? So, you know, start working with people who like you, who share the same vision as you. It doesn't have to be the most important person in the world. Just find someone who is really willing to work with you and who can help you to show that your visions are feasible. And then, you know, you will see that the other people will come later and they will join. Maybe not all of them, but I think this is a really working strategy, and it's much better to invest your resources into collaborations that will work, although they might see as maybe a little bit smaller than the biggest person in the country, but it's not really necessary. And, you know, we had done amazing things with small organization in regions, and it really helped us to build a case that was convincing for the big, you know, big guns later on. So absolutely. Great question. Thank you.
Спасибо за комментарии. Участники чата поддерживают ваш русский
And the attendees support you, and they say that human factor really matters a lot, and it's very instrumental. Therefore, you cannot ignore it, and you need to take it into consideration. And the last question for today, Martin, you were talking about data, about evidence-based approach, on reliance on the data, on figures. What research or studies have you lately done, and can we read them, not in the Czech language? And I understand that a lot of publications are made in your local language, in the Czech language, but could you say a few words about the studies and results, and where can you find them? Where are they published?
Perfect, thank you. Of course, we publish the guidelines, especially the guidelines materials would be usually in Czech, because we want them to make them available for other service providers who would not be reading, you know, peer-reviewed journals and medical journals and things like that. But at the same time, we are trying to do the research in the best possible way. So we also publish a lot of our data in normal palliative medicine journals that you can find online. So if you go to Google Scholar, for example, and you type in Palliative Care Czech Republic, or you can type my name, you will find some of the papers that I was working on. And we always try to publish the data in the proper academic way, because that's also the way how to support the recognition of palliative medicine as a proper part of medical care. And, you know, we have to speak the same language as cardiologists do and as, you know, oncologists do. So just, you know, the local journals in Czech wouldn't really work for us. We really had to publish in good impact factor journals that the other medical professionals would recognize as something, you know, really speaking their language. So I think this is the reason why I would support really collaboration with universities or research centers in your country that can help you do this in like really proper way.
Спасибо огромное, спасибо. У нас осталось еще вот несколько вопросов, но, наверное, мы все-таки...
We have a few more questions, but I think we will leave them for later. We hope that there will be a continuation of this fantastic talk. And we were joined today by Dr. Martin Lucka from the Center of Palliative Care of the Czech Republic. Thank you so very much for your time, for your great interesting review. And we could stay with you forever and ask you about plans, challenges, etc., etc. But we may have another meeting, and we truly hope that it will take place one day. In the meantime, I would like to thank everyone for their presence, and I should remind you that to stay in touch with us is to go to our website, to join our social networks. We are going to copy the link to all our social media. We also have a closed Telegram channel, and fill in the form, join us. We are always happy to see newcomers, and I would like to thank our speaker as well as our great interpreters, Ksenia Rusova and Anna Kmaeva, and the entire BASIT team. Thank you, everyone. And those attendees who are still with us, I would like to ask, once you leave, you will see the feedback form. It will take you a minute to answer a few questions, and for us it's important to know your opinions, so we always welcome in the feedback. Thank you very much. It was very interesting, very informative, and hope to see you next time.
Thank you very much also, and all the best to everyone. Thanks.